enhancing their skills, spreading the message of quality healthcare for safer patient care, a better nation. We have a goal, a noble drive. Hand in hand, step by step, we will fly to march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion, standing right by your side.
So, hello, good morning, good afternoon, good evening, friends, depending upon which part of the world you are joining us from. I'm Dr. Vijay Agarwal, the president of CAHO, and it is my indeed a great pleasure and honor to the third CAHO-ISQua webinar, which has become like a landmark for us, and extremely happy for the topic which is there today on surgical safety. And to moderate this, I don't think we could have thought about a better person than Dr. Nareen Sehgal, good friend of ours. And Dr. Sehgal is a surgeon and one of the earlier adopters of laparoscopic surgery in the National Capital Region, and runs the Sehgal Neo Hospital. Dr. Sehgal is a very renowned person, I'll say, who's associated with many organizations. And of late, now CAHO has pulled him in, and he is a very important pillar for CAHO and a very important now advocate for patient safety and quality. And I give it over to him to welcome Dr. Viviana Rodriguez. And over to you, Dr. Nareen, to take this thing forward.
Thank you so much, Dr. Vijay, sir. First of all, let me start by thanking CAHO to be taking such an initiative. And they have held 53, this is the 53rd webinar. And most of the topics, I was going through the past recordings also, are such important topics and so useful for us. I think it's a fantastic opportunity which the medical fraternity has to listen to people from all over the world, the experts from all over the world giving us such good information. Good evening, friends. It's a warm welcome from my side and CAHO and ISQua to all the delegates who are here today. And also a warm welcome to Dr. Viviana Rodriguez. Today, the topic is surgical patient safety initiatives. We all know that in healthcare, the importance of surgery cannot be underestimated. The statistics show that 313 million surgeries are performed globally each year. That is almost 1 million surgeries every day in this world. A huge number. This itself gives us an idea of the criticality of surgery in management of health in the world. While surgery is done to save lives, but it also carries significant risk. We must understand that unsafe surgical care and procedures cause complications in up to 25% of patients. Up to 25% of patients as per WHO data. A very high number by any standards, and many of them preventable. To deliberate on this important subject of surgical patient safety initiatives, today we have with us Dr. Viviana Rodriguez. She is a specialist in infectious diseases, patient safety, and healthcare quality. She is currently serving as a coordinator of the Department of Quality of Care and Patient Safety at the Institute of Clinical and Healthcare Effectiveness in Buenos Aires, Argentina. Dr. Rodriguez holds an MD from University of de La Plata and doctorate in medicine from the University of Buenos Aires. She's a part of the group of experts with ISQua. Her leadership spans across clinical practice, research, education, and international collaborative projects, including work with the Institute of Healthcare Improvement and multiple Latin American health networks. With over 200 scientific presentations in congresses to her credit and numerous peer-reviewed publications, her recent work has focused on antimicrobial stewardship, quality improvement collaboratives, and the implementation of patient safety strategies in intensive care settings. She also plays an active role as faculty for postgraduate and master programs in quality, patient safety, and infection prevention. So, folks, let's hear from her about all the aspects of surgical patient safety initiatives required today as an essential component of management of our surgical patients to improve the patient outcomes. Anyone can put their doubts and questions in the chat box, and we'll answer those at the end of the talk. Over to you, Dr. Viviana Rodriguez.
Thank you, Dr. Nareen. It's a pleasure for me to be here. Thank you for the invitation to CAHO-ISQua. And thank you to all of you that have joined us today. Good evening, good morning. For me, it's the morning. For you, some of you are evening. And I'm going to share my presentation and start speaking about this topic that is really amazing for all of us. As Dr. Nareen said, the number of surgical procedures in 1 year is huge, and the number of patients that every day have an infection after the surgery is tremendous. Thinking about 1 million per day and more than 10% of patients having an infection is really is a number that puts us in action, that make us responsible to make some changes in the system. I'm going to discuss today some efforts that we have done, trying to understand why some infections, some surgical site infections, happen in Argentina, Uruguay, and Chile. And in the meantime, we're going to talk about the evidence and the barriers and facilitators for improving the process to prevent surgical site infections. So the focus of our work here in Argentina, in the region, as you know, Argentina is the south part of South America, and we are close to Chile and Uruguay. We three together have about 60 million people, and for countries like India or China, we are very, very small countries, but we have all the problems of low and middle income countries for infection prevention or infection or adverse events related to surgical procedures. So I will try to compare the situation of low and middle income countries to the high income countries, where a lot of work has been done, and a lot of work has improved the results of surgical procedures. So, as it has already mentioned, we have a rate of surgical site infections of about 5 to 15% as a global rate. But in the low and middle income countries, it is about 11 to 25, as Dr. Narin mentioned. And in the high income countries, it's less than 5%. So it is surgical site infections are one of the most frequent and preventable adverse events following surgery. They lead to prolonged hospital stays, increased healthcare cost, unnecessary suffering for patients and families. And the good news for this is that there are a lot of things that we can do to avoid or prevent this kind of event. The bad news is that the complexity of the implementation of these actions or initiatives is huge too. The complexity is really astonishing when we saw the number of steps that the surgical process has, and I'm going to talk about it a little bit later. The prevention is not just a clinical responsibility, but it is ethically imperative. And I will try to cover the incidents data, the prevention strategies, the implementation challenges, and the future directions, if we can speak about future in this moment when future changes every day, every hour, and everything is changing on our side. So low and middle income countries have what we can be called as a double burden of disease in adverse events, because we have the need for surgical procedures as any country, as a high income country, but we have probably 10 times more infections after surgery than a high income country. So we have to proceed with surgeries, but after this, we have to face these numbers in surgical site infections. And the factors that lead to the surgical site infections have been mentioned as limited resources, infrastructure gaps, inconsistent guidelines. And I would add the inconsistency of the system. And you were going to listen to me talking about the system, because I'm convinced that we still look through a very, very small space or hole in the problem, and we are not getting better in this trip as some high income countries have done. When we have more money, you can pay for more advanced facilities, you can pay for more capacity buildings. It is to say, more training for people. You have probably more healthcare workers around the surgical procedure, and you have a better surveillance. We have 3 types of surgical site infections. It is just to remind this to you that I'm sure that you know this, but as we go from left to right, the number of infections, the incidence of infections goes down, is lower, but it is more difficult to treat, and the mortality is higher. So we have superficial incisional infections, deep incisional infections, and organ space infections. Superficial incisional infections are the most preventable infections that we could face, and these are the more incidental and the more prevalent in the world. Then we have the deep incisional and the organ space infections that are the most costly infections, and probably those that take the budget, a huge budget in the management of our hospitals. The cost of surgical site infections, sorry about the Spanish in the title. The surgical site infections are the most common and expensive healthcare associated infections because most of them need a second or a third surgical procedure to be treated. So some evidence show that we are paying an annual cost of 3.2 billion in acute care hospitals. If you calculate this in different countries, it is different in the United States from most of the evidence comes, but it is true, and it is something that we have to understand, that the equivalent of this 3.2 billion in the United States is probably the same of any other budget that we are spending in healthcare infections. And if you consider that this calculation is done probably more in the high-income countries, this number could be 10 times higher in our countries, in Latin America, in India, in Africa, or in any other country with less resources. So the burden of the surgical site infections is not only about the patient pain and diseases or sickness, but about money. And this money could be used for different clinical situations. This amount of money has a huge, enormous cost opportunity. So we have to think again systemically. When we go to the prevention side, the bright side of the surgical site or the surgical procedure, the prevention is really, really less costly than the treatment of any infection. So, but the problem seems to be related to those things that we don't see. When we don't see the infections because we have prevented them, then we tend to think, or we tend to think that it's not necessary to implement prevention initiatives because the problem is not there. That is something that happens with all the things in patient safety. When you work hard and you have success, then the problem disappears. And convincing leaders about paying for prevention start being something ridiculous. And it's what's happening with vaccines in the world. When you see people that is against vaccination, it is because we have passed a lot of years without those diseases that have killed a lot of children in the world for a lot of years and decades. So when we don't have the problem, paying for prevention seems something that it could be avoidable. But when you have the problem, the only answer is to react. So we prefer react. We prefer to be reactive to the problem than preventive to the problem. This is one of the factors that place the middle and low income countries in the situation of having 10 times more surgical site infections than a preventive culture of patient safety. Speaking especially about colorectal surgical site infection, that is a procedure that we have studied a little bit deeper here in Argentina. We know that cancer patients have immune suppression, longer surgeries, and complex procedures, and this places them into a higher risk of surgical site infections. And non-cancer patients have a different risk. So we can expect that cancer patients have more surgical site infections. But in any case, we have a lot of tools, a lot of initiatives that could prevent these surgical site infections. I'm going to show you our one experience that we have that we did about 5 years ago. It was a study about the adherence to a minimum prevention bundle and the prevalence of colorectal surgical site infection in Argentina, Chile, and Uruguay. Unfortunately, Chile participated only during the phase of consensus about the bundle, and then the prevention or the cohort, the descriptive cohort about incident of surgical site infections was done only in Argentina and Uruguay. We are very, very similar countries. We have similar population, and we included similar hospitals in the study. It was a very small study in only private hospitals, and I will try to tell you the story about this. In Latin America, the surgical site infections affects a higher percentage of patients. It is calculated about 8 to 30%. And as I said, the comparison to high-income countries is about 10 times. Although effective preventive measures and medications for colorectal surgical site infections are well established, are well known, there is a lack of evidence regarding adherence to these interventions in the region. This is the classical gap between science and implementation, and the topic of our generation is implementations, because we have to close the gap between the knowledge and the adherence or the compliance to these recommendations. The aim of this study was to define a minimum prevention bundle for colorectal surgical site infections and to estimate the prevalence in private health care centers in Argentina and Uruguay. It was the incidence, not the prevalence, sorry. This study included 2 phases. A first phase, when we did a modified Delphi consensus involving 14 experts from Argentina, Uruguay, and Chile. We included surgeons, infectious disease specialists, and infection preventionists. And the aims, the objective was to define this bundle from 19 recommendations that we have found after a systematic review of the evidence. And in the second phase of the study, during 2022, we started measuring the number of surgical site infections in this in the organizations in the hospital that participate of the study. So for the first part of the study, this modified Delphi overview, we have a review phase, we have a scoring phase with the experts, and we have a consensus phase with final recommendations. In this summary, using the technique, the method of UCLA process, we have an expert of 14 specialists from different specialties, as I told you. We review 19 practices. We evaluated 19 practices, and we defined 13 criteria or parameters in order to select and prioritize the elements of the bundle. And the consensus finally took 6 primary interventions that were the most feasible and viable for our region and for our situation in private hospitals. Those elements were very simple, and we consider that the attire and the hand hygiene and all the procedure of sterilization or decontamination in the operation room were similar, and we assume that it was like this because all the hospital had the estimated same surgical site infection rate before starting the study. It was a pilot study. It was only aimed to measure and to estimate the incidence of these surgical site infections in order to plan, if we had more resources in the future, a collaborative implementation for reducing the surgical site infections. But what we included in the bundle was the antiseptic, alcohol antiseptic during the preparation of the skin. It could be with chloroxidine or with povidone or iodine. And it was not prescriptive. We only recommend to use something with alcohol in the antiseptic preparation of the skin. Then in a standardized antibiotic prophylaxis that had to be following a local guideline according to the epidemiology of the hospital or the region where the hospital was placed. Then in a standardized mechanical bowel preparation, oral and local, and it has to be, again, locally standardized and not prescriptive. The fourth component was the glycemic screening and control perioperatory, the first 24 hours before and 48 hours after the surgery in all the patients that have the diabetes diagnosis or that have had a high glycemic level before the surgery. Then again, the standardized pre-surgical basing, and this has to be standardized by the hospital, and we suggested to use some of the recommended standardized pre-surgical bath, but they could do it with plain soap, or they can do with antiseptic soap. And finally, normothermia. And what we found was that this study needed around 113 patients, assuming that our prevalence or our incidence of surgical site infections was about 10%. And we were going to ask the organizations, the hospitals, to measure the adherence or the compliance with this antimicrobial prophylaxis, normothermia, glycemic control, antiseptic with alcohol, colonic preparation, and pre-surgical bathing. Finally, in this study, a total of 166 patients were included and assessed. Among them, 11 patients were readmitted. It was a 7.3% during the surveillance period, and it was noted that 18 patients could not be contacted after 30 days following the procedure. The recommendation of following up a patient after 30 days is something that is regular and accepted in most of high-income countries. But here in Argentina and in Argentina especially, it is not a regular practice. Chile have this practice already standardized, and but unfortunately they do not participate of the study. And the hospital that participated from Uruguay had this practice standardized before the study. And the characteristic of the population from the different hospitals were similar, and we have a number of infections that were expected for this kind of procedure. We had the number of clean contaminated surgeries were the most prevalent, and then we had some contaminated and dirty surgeries that were expected too. So we have this prevention bundle that we measure as a total, it is recommended to measure a bundle as a yes or no data, as a binary data, that was complete only in 6% of the patients. And then we measure every element of the bundle, and we find out that the colonic preparation, besides being something not prescriptive and followed by a local guideline, was the less present element of the bundle. It was 13% of the patients received a colonic preparation and a standardized colonic preparation. And then you see in the table that antimicrobial prophylaxis and glycemic control were the most present. The outcomes were a surprise for us, but what we were waiting for from the evidence. We were waiting for less incidence of infections in these hospitals because they were private and they were they were academic, but the surgical site infections within 13 days was about 30%, as Dr. Norin mentioned at the beginning of the presentation. And the surgical surgical process cycle was about 64 minutes, the mean time. And the 30 days readmissions for patients was about 9%. We didn't find, after following the patients, 117 patients after 30 days, we didn't find any death in this group. So low adherence or low compliance with the elements were the preoperative bathing. The bath was something that was very difficult to standardize and to complete. The normothermia and the glycemic control and the high adherence measure were the antibiotic prophylaxis and antiseptic scheme. As our conclusion, this collaborative effort between surgeons and infection preventions, because one of the main points of our study was to engage surgeons in the process of preventing surgical site infections. And it was something really challenge, because surgeons are usually more involved in the phase of the surgical procedure than in the pre-operating moment or after the surgery. So it was an effort. The adherence to the 6 elements was estimated about 6%. The infections were about 30%. And building upon these findings, as I told you, we are thinking about making or implementing a new study, a collaborative, that we are trying to find a grant or some budget to do it after having this kind of information. What we found too was that there was a strong resistance to report data from some of the hospitals, and we suppose after talking with the infection control preventionist that the measurements and the analysis of the data was not so accepted or so included in the regular task of a doctor of the surgical team. So going to recommendations in general, World Healthcare Organizations, we have high evidence for alcohol antiseptics. We have moderate to high evidence to oral antibiotics and mechanical preparation. We have moderate evidence for normothermia and glycemic control in this moment for colorectal surgery. This the bundle that we used was selected because we tried to follow the recommendation of not having too many elements, but only those that were possible, viable, and accepted for the population that we were going to include. But the number of infections shows that a lot of elements that are recommended could be included or should be included in the perioperative process in order to reduce this 30% to 3 or 5% that have the high-income countries or more developed hospitals in the region or in the world. So the challenges was in constrained resources, the challenges are limited supplies, limited leadership, training deficit or low capacity building, surveillance gaps, the lack of technology, and the lack of coordination of the process is a problem for surveillance, and the cultural resistance. We are still used to work without any analysis of our performance. So the cultural resistance, and not talking about our study, but in general in the region, is a challenge. When we have to include indicators for monitoring this kind of events, we have a lot of indicators that we can measure, but we have to select those that shows us the complexity of the problem and that could give us a tip, a hint of where to start with the problem and to start for a solution for the problem. What we cannot negotiate is standardized data and the feasible workload for the measurement and the analysis for a target improvement. So in general, the surveillance limitations in all our countries are related to post-discharge data loss, the problems with continuity of care we here in low-income countries or middle-income countries is not so frequent to have a seamless care, as it's been said in some countries. And the lack of this seamless care makes that the patients lost to follow up, the infections detected in a different hospital, and we have incomplete reporting. And the other problems have had to be with the lack of technology, with the need of a manual reporting system, and the lack of information from some points of the process, especially from the pre-operative part of the process, where the recommendations before the surgery, like stop smoking or nutrition or any other recommendation that could be useful, are very difficult to identify and to monitor. As future directions, we have a lot of technologies that could help us, like artificial intelligence, global alliances that is not a technology, but should be a cultural activity or behavior that we should include. And we have the responsibility to create capacity building in low and middle income countries for stopping or preventing all the surgical site infections and surgical adverse events. Concluding my presentation and ready for some questions, if you want, I could say that surgical site infections are a global priority. The number of lives, the number of years of the years lost, and the number of resources that we're spending that have a very high cost opportunity are the points that we have to remember. The bundle approach needs multiple interventions because the problem is multifactorial, but keep in mind that the number of elements has to be less real. And the monitoring is essential. If we monitor and we don't analyze and we don't do consequence, we don't act in consequence, going back to our cycle of PDSA, the monitoring something and not doing something is just a loss of time. And something that a phrase that I now try to remember always is that we have to make patient safety inevitable. And this is thinking about from the systemic point of view. If we build a system where patient safety is inevitable, then the results will be better, and our healthcare workers will be safer and happier. Thank you very much for the invitation, for the attention, and ready for questions.
Thank you so much, Dr. Viviana. I think excellent talk where very early I could realize that all the problems that you are mentioning and the methods you have suggested of solving them is very similar to our country, India.
Mhm.
And I think what I could conclude from this is that surgical harm is rarely the result of a single failure. It is usually a combination of system weaknesses, communication gaps, and human factors. By understanding where things commonly go wrong, that is what you have tried to analyze and show to us, we can build strong barriers to prevent them. It is such an essential part of human healthcare that a lot of importance needs to be given to this. Anybody has any questions? There is, I see one question there. There is a question from Shaikh Pachmea. What he says is, before any surgery, the treating team given antibiotics to the patient before surgery. Time to give antibiotics is it varies between hospitals to
Entirely.
hospital, country to country. Can you tell what is the ideal time to give the patient before surgery? Given
Yeah. The antibiotic as a prophylaxis for surgical site infection, it's only needed during the incisional phase. It is to say that we need the higher amount of antibiotics in the blood of the patient when the surgeon makes the incision. So we have to calculate the time that needs the antibiotic, if it is taken orally or intravenously, for getting to the peak in the blood during the surgeon incision practice. It's something that we have to coordinate. Which antibiotic and the time of the antibiotic is the most important part of the prophylaxis, talking about antibiotics. Then after this dose, the use of antibiotics, it's controversial. And before this, before the surgery, if the patient doesn't have an infection, it's worse for the patient because we are pushing the bacteria of the patients to be more resistant. So we will have an infections with a resistant bacteria because we use the antibiotics before, and some new bacteria that were a little bit hidden in the patient will appear after the surgery or during the surgery because we have killed those sensitive bacteria before the surgery. The physiopathology of the surgical site infection has to be with the amount of time that we used for the procedure, the preparation of the patient, the normothermia, the glycemic control, all the things together. And this is something that we have to understand. The antibiotic has only one shot or only one point in the surgery prevention, and it has to be perfect. It has to be in the moment that it's necessary and not more before or not more after.
That's so true, Dr. Viviana. I think the best time to give antibiotic and a single shot, especially in clean cases, is within 1 hour of induction of anesthesia.
Yeah.
And the best way to not to forget or to make mistakes or to miscalculate the time, because sometimes the patient may not be wheeled in on a planned timeline. So best
Mhm.
time is when you induce anesthesia, you give this first shot also. This is what I believe and we've been practicing.
Yeah.
So another question from Sangeeta Kamatachi. Is bowel preparation mandatory?
For colon surgery, yes, it is mandatory. And there are always some controversies about how do we prepare the patient and when do we prepare the patient, and this is something that we have to be updated all the time, because sometimes the evidence changes or some new preparations appears. But a bowel preparation, when it is possible, course, because sometimes the patient has cancer and an obstruction or needs some urgent procedure. What is possible is it's a better situation for the patient. So the answer would be it's mandatory when it's possible, and it's not prescriptive, but related to the evidence and the effectiveness.
True, Dr. Viviana. But what I have realized in past couple of years, a lot of people who are doing surgery which is not directly related to colorectum, sometimes maybe like hysterectomy or endometriosis, where you only you suspect that bowel may be transgressed. People are
Okay.
not giving bowel now.
Okay. No. Out of the colorectal surgery, the preparation of the bowel is not mandatory. It is sometimes probably we should think about it. We should consider with an expert panel, or we should look at the patient and see what are the risks of the patient of breaking the barrier of the colon during the surgery, because not every surgeon is the same. But it is not mandatory for all the surgeries, or the abdominal surgeries, or the pelvic surgeries. It is only mandatory for the colon rectal surgery and when it is possible.
Thank you, Dr. Viviana. And there is another question from Irene Saldana. Can we have one checklist for capturing the SSI and RCA?
RCA?
Root cause analysis.
Root cause analysis. Yes. Can we have one checklist for capturing this with I don't understand the question, but I think that we can do a checklist with everything we need to check in a process, because a surgical procedure has a very clear process since the preoperative to the postoperative phase, and we have a checklist for the surgery. The World Healthcare as an organization have the checklist, and we can use it as a base, as a baseline, and then we could add some elements to this checklist in order to see if the root cause is during the pre phase or operation phase or post-operation phase.
Yeah, I think the question is not very, very clear. Probably that answers the question. Another question which is there is, if the patient is already on IV antibiotics, is it necessary to give antibiotics prior to surgery?
It is necessary to first adapt the antibiotic to the bacteria that we are waiting for in the site of the surgery, and we have to adapt the timing of the antibiotic. As I said, we need the level of antibiotics in the peak of the concentration in blood during the act of opening of the surgeon. So if the doctors open the skin and the site of the surgery has to be full of antibiotics. So if we have a patient in antibiotics and the patient received the antibiotic 3 hours before, and then he needs another dose 3 hours after, we need another dose because the level of antibiotics is not going to be the best for the surgeon. So this is the answer for this. It depends of the timing and bacteria that we're waiting for the surgical site infection.
Very right. I think you've answered that question, that the level of antibiotics at the time of incision has to be high. That is to be kept in mind. And second thing, even if the surgery is prolonged, then after 2 hours, it holds merit that you repeat 1 dose of antibiotic.
Yeah.
Am I right, Dr. Viviana?
Yeah. When you lose a lot of blood during the surgery, actually, if you lose blood, you lose the carrier of the antibiotic. So you need to repeat the dose, and in order to reinforce the dose of the antibiotics, and after the time that you consider that the middle time for the dose of antibiotics is being reduced, you have to repeat it. Yes.
Another question: any specific antibiotics for all surgeries?
Unfortunately, no. There is not only one antibiotic for all surgeries. We usually, what we did in the hospital was to make some charts for every specialty and for every surgery in the specialty, and we placed the charts in the operation rooms with a plastic cover in order to clean it. And we put these charts in the anesthetic cart. So the anesthesiologist or the technical anesthesiologist could be aware of the antibiotic that was recommended for the surgeon for the surgery that was being conducted. It was easy. It was cheap, but it has a problem. They were beautiful, and sometimes the doctors or somebody like to take them home or to other hospitals. So you have to consider to place them and to replace them anytime it's needed.
Thank you. There is another very basic question. What about part preparation? Can we use a blade?
Sorry, I didn't understand. About part preparation.
Asking
okay.
In preparation.
See, yeah. No, we don't have to use. We have to cut the hair. We don't have to make any disruption of the skin. And the disruption of the skin is usually done by the shaving blade. So the recommendation is not to use a blade in order to take off the hair, because we are going to disrupt the skin before. And if we disrupt the skin, the speed of the duplication of bacteria is going to be higher, and the the opportunity of the bacteria to go deeper is higher too.
That's right. So the answer is that we use clippers, and it is best to use
Yes. The
on
best
operation
is
table
clipper
itself.
or scissors if you have long hair in some part of, like in the head, to use a scissor or to use a clipper that you have 1 or 2 millimeters of space between the skin and the cut.
Right. There are a lot of questions coming, but we have
Yeah.
limitation of time. So one interesting question: when SSIs occur despite full compliance to protocol, how should liability be assigned, and how can institutions balance transparency with medical legal risks? What is your take on that?
Place. I shouldn't. Well, I think that in this case, we have to remember about just culture. When a protocol is being has been not accomplished, there's not compliance with the protocol, we have to see if the protocol is feasible or is possible for the hospital and for the team that is working in the hospital. If the deviance or if there exists a normalization of the deviance of the protocol, then probably the protocol is not good for the team or for the hospital. But if the protocol is good for the hospital, good for the people, and somebody takes a shortcut because it's needed or because it was difficult to live with this situation, is one thing. And if the if the person takes the shortcut because it was just a reckless behavior, we had to think about what to do with this person in order to avoid repeating this conduct. We have to think about the error, the deviance or the shortcuts and the reckless behavior, because these three situations are very, very different, and the answers to these situations are very, very different. The two first, the shortcut and the error, needs an analysis and needs some kind of redesign probably of the protocol, procedural processes, and education and capacity building. But the reckless behavior needs to be avoided, and the hospital will take the measures or the decisions that have to take with this professional.
Right. I think we should all understand that infections do occur despite all precautions, using the best antibiotics, using all the protocols, following all necessary risk prevention methods. We should not actually start blaming anyone. We can do an RCA, root cause analysis, and learn from our mistakes rather than start a blame game. That is what I feel. And that only helps us in strengthening our processes. And if there are any gaps, we can basically look after them. Thank you so much, Dr. Viviana.
Pleasure.
It was a fantastic lecture. We really learned a lot from this, though I think surgical patient safety initiatives it's a very long topic, and there are a lot of other elements which also can be discussed, but in 1 hour I think it is not possible. But I think you've done a wonderful job. Over to you, Dr. Vijay, for your final comments.
No, thank you. I think very stimulating talk, and that I think also should inspire us to conduct a similar study. We can think of a collaboration also with you. We can look at your protocol, that was used in your country, but I think we should also do a study to see whether which bundle or something can help us preventing the surgical site infections. And I think at least some studies need to be done on this. We have a lot of our people here, Dr. Malati, Dr. Jayalakshmi, and many. I'm sure they are taking note of it and will be creating a protocol for doing a study on this. So that's wonderful. So it will be our proud privilege, an honor to hand you over a certificate of appreciation. We will be posting it to you. So thank you very much, Dr. Viviana Rodriguez. We are very delighted that you are, and I hope that you will now become a part of the CAHO family and to help
Absolutely.
us promote the issues of patient safety. So thank you very much. We will be mailing it to you, and so nice of you that you are here.
Thank you. Thank you for the invitation and the opportunity.
Thank you so much. We'll just take a couple of more minutes to go through the next webinar. The 54th webinar will be on technology as an enabler, I think, and is by another very, very renowned speaker, Dr. Fabio Gastal. And so, guys, do not miss this opportunity. 3rd June 2025. Let's listen to Dr. Fabio on technology as an enabler. So that's the 54th webinar. This is once again kind of a reminder for the ISQua fellowship, and you can enjoy a 10% discount on the ISQua fellowship with the code CAHO2024. Okay. So go ahead. And now the CAHO monthly quality meeting initiative, we are already promoting that every, at least our hospitals should start telecasting this particular webinar on the every first Tuesday of the month. Let's make it a monthly quality meeting. And I think this is being adopted. Thank you very much. Go ahead. So today the participants have been the Vijaya Medical Educational Trust, Chennai, Mehta Multi-Speciality Hospital, Ganga Medical Center, Coimbatore, Medica Super Speciality, Kolkata, Fortis, Mohali, Punjab, Rajagiri Hospital, Kerala, Baby Memorial in Kozhikode, Kerala, Bethany Hospital in Meghalaya, Sri Ranga Hospital, Chengalpattu, AJ Hospital in Mangalore, Bombay Hospital in Mumbai, Nirmal's Eye Hospital in Chennai, Jabalpur Hospital and Research Center, Madhya Pradesh, Christian Medical College, Vellore, Kaveri Hospital, Tamil Nadu, Institute of Neurosciences, Kolkata, West Bengal. So, and there are more: Medica Super Speciality Hospital, Kolkata, Nazareth Hospital, Shillong, Meghalaya, Christian Medical College, Ranipet Campus, Sehgal New Hospital, New Delhi, and ILS Hospital, Damdam, Kolkata. So thank you very much, these hospitals, and I'm sure that next time the number should double, please. And so we have this already. The 53rd webinar has been conducted thanks to Dr. Viviana Rodriguez. The upcoming activities are our training programs, which are on quality tools and techniques, which is on the 9th May. It's virtual. Hospital infection control basic program is there on the 10th May. Migration from ISO 15189 2012 to 2022 is on 17th May, and hospital infection control advanced program is on 17th May. So friends, do register yourself. Then there is a training program on quality and patient safety in dental practices, and that's on 25th May. Clinical audit on 23rd May. Quality implementation in hospital basic program on 10th May. An infection control link for a nurse course is on 30th May. We have nursing quality improvement program on 26th May, nursing excellence standards on 24th May, certified professionals in healthcare quality, CP HQA preparatory course, and that is on 6th June, and antimicrobial stewardship on the 5th of June. So, and on-site training programs are there on the CPQIH Advance, which is on 19th June at the Chirai Beach Resorts, Kochi, Kerala. And we have the surface cleaning and disinfection in healthcare facilities on the 30th May at Nazareth Hospital, Shillong. So, and of course, we have the IIM Shillong and CAHO. This offers a 6-month executive program in healthcare management. This program is just going to get started. Any last minute person who wants to enroll for this program, please get in touch almost today. We can see that how can we accommodate you. So next is the CAHO National Certifying Exam for Infection Control Professionals. And now the exam date is 12th June 2025. CAHO National Certifying Examination for Infection Control Professionals, that is the batch 5th, will be coming soon. And so please get registered. Then the CAHO's CSSD program registration is now open. That is the Awareness, Compliance, and Excellence for CSSD program for the hospitals. So thank you, friends. And it's indeed a great pleasure. And now you know that CAHO is also going to have a program in Dubai on the 9th of May, which is like a CAHO International Convergence Dubai edition. So after Nepal and Sri Lanka, we are very happy to have our footprints now in Dubai. So thank you very much, and good evening and good morning, depending upon where you are from. Thank you.
Sir, can we have one photograph, sir?
Yes, can everybody put on the video, please, so that let's have the picture. Prakash, you also put on your, yeah, let's have, everybody should put on the video,
Absolutely,
please.
sir.
Please give your feedback about our programs, this program, as well as the other programs. Your feedback is what makes us go. Yeah, thank you. Please put on your video. Major Dr. Shivakumar, Dr. Francis Roy, they're waiting for you. Yeah, thank you. Thank you. All right. Okay.
Thank you, sir.
Thank you. Thank you. Bye.
Thank you to all the delegates as well. Thank you so much
Thank you.
for patiently
Thank you, Dr. Viviana.
participating.
Thank you again.
Okay. Thank you.
Bye-bye, Dr. Viviana Rodriguez.